Hello, and welcome to Wellness Wednesday with 3W. Wellness Wednesday is sponsored by 3W Medical for Women, a nonprofit medical clinic offering free of charge or low-cost reproductive health services to women in the Seattle area, regardless of income or insurance status. 3W does not profit off of the reproductive health choices women make. The information shared in this podcast is the opinion of the speaker or speakers. Medical information is not intended as individual medical consultation, but for general education only. Always consult your own health professional for personalized advice regarding medical decisions. And if you're in the Seattle area, consider making an appointment to consult with us. I'm Helen Nguyen, CEO and co-founder of 3W Medical for Women and the host of today's podcast. Hi there, listeners. This is Wellness Wednesday with 3W. This is Helen Nguyen, CEO of 3W Medical for Women. I'm your host today. Well, actually, I'm your host for a lot of these episodes, which I'm so glad to do. I'm so glad to do it. Today, we have, again, our medical director and president, the lovely Dr. Susan Rutherford, and we're going to be talking about a pretty fun topic today, multiple gestation. I can never say that word right.
Gestation.
Gestation.
Yeah,
okay.
Multiple gestation.
Yeah. What does that mean?
So it means more than one baby at a time.
Oh, fun.
So people usually think of twins.
Yes.
But you can also have triplets.
Okay.
And you remember the octomom.
Yes.
Yeah.
What do you call her? Is that
that's
still?
just a higher order multiple gestation.
Okay.
So you've got twins. Triplets are actually considered a higher order multiple gestation as well. But
okay. And it's
triplets, quads.
Okay.
Yeah.
Do you know how often multiple pregnancies happen, multiple gestations occur?
Yeah, it's kind of interesting. So there are two different kinds of, say, twinning, if we just limit it to the topic of twins for the moment.
Okay.
One is identical and one is fraternal. Mm-hmm. Okay. Mm-hmm. So the incidence of the identical twins is about the same throughout the world. And it's about 4 per 1,000 births.
Really?
Okay? Those identical twins. Yeah.
Wow. Okay.
The fraternal, those are called monozygotic.
Wow.
There's dizygotic, which means they came from 2 fertilized eggs. And that varies with population, with age, and these numbers have been changing. But in the United States, for example, for age, dizygotic twins are about 3 per 1,000 if they're under 20 years old. So about the same as the monozygotic. But if you go to the ages 35 to 40, where it gets significantly higher, it's 14 per 1,000.
Why is that?
It just increases with age. But interestingly, above 40, it goes back down again.
Okay.
It's also the lowest incidence is among Asians. The medium sort of moderate incidence is in the whites. And the highest incidence is among the blacks.
Wow.
Yeah. There's a famous tribe in Africa, the Yoruba tribe, that we all learn about in our textbooks.
Oh, really?
They have a very, very high incidence.
So,
yeah.
So why does it happen? Does it happen to do with genetics? Like, I've heard that.
Well, the monozygotic doesn't have to do with genetics.
Okay.
Okay. The dizygotic does. And it's on the mother's side of the family, not the father. Huh. So if the couple comes in and say, well, on the dad's side, there are twins. It's like, well, that doesn't make any difference. Sorry.
Yeah.
That doesn't make any difference. But on the mother's side, if there are twins, then she's at a little higher risk. But if they're not identical, if they're fraternal twins,
right,
the dizygotic twins, she's at a little higher risk.
What type of significant health risks are there when you have multiple pregnancies?
Like, well, I kind of like to talk about that last.
Okay, sure. Yeah, no worries.
Yeah, because I'd like to talk a little bit more about some of these numbers because I gave you some of these numbers, but those, if you look at the period of time between 1980 and say 2018, there's a huge increase, like a 70 to 80% increase in the number of twins in the United States.
Yeah. Why is that?
So you heard of assisted reproductive technology.
No, what is that?
Yeah, ART. Well, that's like the in vitro.
Oh,
That's
okay.
using hormones to try to help people get pregnant that maybe have issues with infertility.
Yes.
When you use some of those medications, there's a higher incidence of twins or triplets. And in fact, the incidence of, say, triplets or quads, it goes along with the dose. So the higher the dose of some of those medications. So a lot of them are done. People with infertility will know that they go in and they get a prescription for a little bit for 1 month, and then they have to go back next month. And if they didn't get pregnant, they get a little bit higher dose. And you keep gradually increasing it.
Right.
Yeah. Well, the result of that can be the higher order multiples. During the 80s and 90s, the increase in the number of higher order multiples in the United States was 400%. Yeah.
Oh my goodness.
Yeah, really increased. That's the issue with the assisted reproductive technology.
Okay.
So, and I wanted to talk about that a little bit because, you remember the Octomom, I mentioned that. Well, for a while, some of the doctors who were doing the in vitro fertilization were just putting in as many fertilized eggs and as many embryos as they could in hopes that something would take because of the fact that each cycle is very, very expensive.
Yes.
$10,000 to $20,000 a cycle.
Yeah, I've heard.
Yeah. So they'd put in lots, and then, but what if all 5 or 6 took? Well, now you're dealing with an issue of losing those babies to prematurity and stillbirth. And after all the work you went to, so, we really don't want that many, so what do we do? And the practice was to then send them to somebody in maternal fetal medicine. I never did it, but other maternal fetal medicine specialists did do what they called embryo reduction. And basically what they're doing is taking a needle and going in and injecting lethal, usually potassium chloride, in there to kill some of the babies. So you take it down to, say, 2.
Even though they're healthy and viable.
Right. Yeah.
Wow.
The problem is that, if they're born at 24 weeks, then they could end up not surviving or surviving with severe handicaps. So, so that was a problem. Things have mostly changed in that environment, so that most of the people that I've talked with who are doing the reproductive infertility treatments are putting in 1 or at most 2 embryos. Their success rate has gone up, so they're not probably so desperate, but also that's more ethical. But I'm sure that there's probably some places where they're, putting in more. Yeah. But you're asking for a lot of trouble with that, not to mention the ethics of, so the selective reduction. How did they choose which ones? Yes. How did they choose which ones? Yeah. It was the ones that they could most easily get to under ultrasound guidance with the needle. So if you had one that looked kind of smallish already, or whatever, but it was hard to reach, that one would not be killed, but the healthy one that was on top, that was easy to get the needle to, would be killed. So that's kind of a sad piece of this. Yeah. But the good news is that for the most part, things have gotten more ethical. But that's the biggest reason behind all the huge increase in multiple gestation. Okay. So let's talk about the naturally occurring multiple gestation. Yeah. So I mentioned older maternal age, it increases the risk. Also, if you've had a lot of children, separate from your age. So somebody that's had 1 child is at lower risk than somebody who's had 5 or 6 kids. They're at a higher risk of ending up with a twin pregnancy. You can have this coming from the same egg, as I mentioned, monozygotic, which is where it splits at a certain time, or the dizygotic. If you've got triplets, you could have, it's rare, but you could have all 3 triplets from splitting. They could be identical triplets. Wow. That's pretty uncommon. Okay. Most of the time, triplets, you might have 2 of them that are identical and 1 that's a sibling. The ones that are fraternal have the same genetics, just as if it was two different siblings, just a different time, but the same couple.
Yeah.
The same parents. It'd be
So
just as if
interesting.
one was born one year and another was born a different year.
Yeah.
But the monozygotic, the identical twins, they have the same genetics. They're the ones that typically look alike.
Yeah.
That sort of thing.
Dress alike.
Yeah, sometimes
Can read each other's thoughts.
Maybe. Yeah. So
what happens, and I know you might not have the answer to this, but what happens? I've heard a lot of pregnancies that one twin absorbs the other.
So there are situations where there's an increased risk of miscarriage.
Okay.
Say you have one twin, they've called it the vanishing twin, for example.
Yes.
Early in pregnancy.
Yeah.
And you think you saw two,
Yes.
but then the other one there's just a little bubble of fluid or something and it sort of disappeared. Yeah.
Mm-hmm.
When that happens really early, there's no apparent increased risk. Like it's not a twin pregnancy risk. It's not a risk of prematurity, that sort of thing. When it's early in the first trimester that pregnancy, that one of the twins is lost.
Okay. Is that
so? Then it becomes just like a regular singleton pregnancy.
okay? Is that pretty common that happens, or?
Well, miscarriages are common in general. 20% of pregnancies. So it's probably more common than we think.
Okay.
One of the challenges is figuring out, are they monozygotic? Are they dizygotic? Because the risks are very different for the pregnancies. And are there twins? And frankly, that's one thing that's good about our clinic is that people can get access very quickly to confirm whether or not they have a pregnancy.
Yes.
And the ultrasound very early. A lot of times people aren't getting appointments with an OBGYN doctor
3
until,
months out is what I heard.
8 to 12 weeks gestation.
Yeah.
The best time to tell if it's truly monozygotic or dizygotic is actually before 8 weeks.
Wow.
Before 9 weeks.
That's pretty early.
Very early, yes. They look very different on ultrasound at that point. Wow. You can clearly see two separate little sacs and bubbles if it's two separate pregnancies. That doesn't guarantee that they didn't split really early, by the way. But
okay.
Yeah, but it's really important to sort that out because placental sharing increases the risk.
Okay.
So,
and what is the difference between identical twins and fraternal twins?
So the identical are the ones that came from one egg.
Okay.
It got fertilized. There's the postulate that egg could have split somehow and you got two sperm fertilizing the same egg and then it split. So they would be fraternal.
Okay.
But that's probably really rare.
Okay.
Usually it's one sperm fertilizing one egg and then it divides into two pregnancies. I mean, obviously division starts right away, cells dividing. If it's within the first 3 days after fertilization, then you're going to end up with two separate placentas, two separate sets of membranes. There's the inner membrane, the amnion, the outer one, the chorion, which is really the chorion, the placenta is part of the chorion.
Okay.
Yeah, and if you get those split really, really early, you won't be able to tell if it was because the eggs split or because it's two eggs that got fertilized separately that happened to be at the same time. So somebody ovulated two eggs.
Yeah.
That's the fraternal.
Okay.
Two eggs. The identical is when you have the one egg and it splits. Okay. But if that split happens before 3 days after fertilization, then you won't be able to tell the difference by ultrasound.
Okay.
So not until after delivery. If the split occurs 3 to 8 days, then you end up sharing a placenta and the chorion. So that's where it will also look different on ultrasound beyond 8 or 9 weeks when you get into the second trimester even, or maybe even the third trimester, you'll be able to tell the difference because there are two layers of membranes. There's the inner one, the amnion, which I refer to patients as the lining of the baby's swimming pool. Okay. If they have two separate swimming pools with linings inside the outer shell of the chorion,
yes,
then they're still identical. It's still monozygotic, but they're not going to get into trouble like tangling their cords around each other.
Oh.
Yeah.
Because they're still in kind of their separate spaces?
Right.
Okay.
Right. So if the split occurs after 8 days, and by say 13 days, that's when you end up with the babies sharing totally the same swimming pool liner.
Mm-hmm.
And that's when their cords can get all tangled.
Does that happen often?
Oh, yes. It happens very commonly if they're in the same sac.
Oh.
Yes, because the recommendation now is to go ahead and deliver those patients at 34 weeks, which is preterm.
Yeah.
And they'll need some special nursery care and all of that.
Yeah.
And they could have breathing problems, could end up needing some assisted ventilation. Mm-hmm. They could have prematurity problems. Mm-hmm. But the reason for that recommendation is to avoid the babies suddenly dying unexpectedly. Those babies, sometimes the heart rates are monitored. Sometimes they're just stuck in the hospital under, very frequent, if not almost continuous fetal heart rate monitoring to see if there's any evidence of cord compression that could be caused by cords getting tangled. Mm-hmm. And I've had women that we came into the hospital and just stayed until they had their babies. They came in at 26 or 28 weeks. So there was signs of something happening. We'd deliver them early.
Wow.
So that, so they had live babies.
Right.
Yeah. So, but that's between the split between 3 and 8 days.
Okay.
So if it's after 8 days, between 8 and 13 days, that's the same shared swimming pool.
Okay.
Everything. Okay. Mm-hmm. If it's after 13 days, by 15 days, that's when you end up with conjoined twins. That's the Siamese twins.
The Siamese twins.
And they can be joined at all sorts of different
places.
Yes. Head, chest, abdomen, shoulders areas.
I don't see a lot of them anymore.
No,
I used to see them in the news all the time.
Yeah, it's about 1 in 50,000 pregnancies.
Oh, wow.
Yeah, so it's pretty rare.
Yeah, I just remember growing up and hearing more of those situations happening. I wonder if they're being diagnosed earlier and terminated earlier.
That's probably what's happening. Mm-hmm.
I see. Okay.
Yep. Because it's definitely something that you can diagnose, certainly in the second trimester.
Mm-hmm.
And if, depending on what that looks like by ultrasound, there might be plans for a delivery where you've got the pediatric surgeons, the pediatric neurosurgeons, you've got all of them, and you deliver and in one room, and the babies go into the next room, and they're separated. And that's one of the things that Ben Carson became famous for. Oh, really? Yeah, he is a pediatric neurosurgeon. Oh, retired now, but he's the one that ran for president.
Yeah,
people might remember that. Yeah,
yeah,
that was his specialty. I mean, he did a lot of world famous cases.
Yeah,
but you're probably right. You don't hear about it much because so many people, almost everybody has an ultrasound
right
now, and the majority, particularly if they're sharing a heart or something like that, the chance of survival is pretty slim. Yeah.
Yeah.
So,
and why is
after 15 days from fertilization, there can't be any more splitting. So,
yeah, that's good.
Yeah.
And why is it important to diagnose multiple gestation?
Yes, because of the increased risks.
Okay.
And that's why I wanted to talk about it.
Yeah.
Sort of last. So why talk about this? Why find out about it early? So there are baby issues and there are mama issues.
Okay.
The baby issues, if they're identical and they're sharing a placenta or sharing a sac, then that pregnancy is going to require a whole lot of very special attention by people who are doing ultrasounds. A lot. Okay. I mean, the minimum number of ultrasounds that a woman with a multiple gestation would get would be monthly.
Wow.
But it's not unusual if some of these problems start to develop. You can have blood vessels connecting one baby to the other through the placenta, and one baby can transfuse the other. So one baby is real small and the other gets really big. And either one of those babies can get heart failure because the heart's either having trouble dealing with too little or too much blood.
Yeah.
Yeah, that can be treated rather successfully. Not all the time,
Mm-hmm.
but rather successfully when the woman's pregnant in the second trimester.
Okay.
By going in with a scope, like you've heard of a laparoscope, so
Yes.
a lighted tube, going in and going into the uterus and inside of the bag or bags of waters,
Okay.
and laser coagulating, i.e. cauterizing, burning the places where you can see on the surface of the placenta that these vessels are connecting between the two babies, so that you interrupt this transfusion from one baby to the other.
Yeah.
Yeah.
That's amazing.
Yes.
Wow.
The earliest I've heard of it being done is around 14 weeks.
Wow.
But it's more commonly done around probably 18, 20, something like that.
Mm-hmm.
It depends on when you start having problems.
Mm-hmm.
But you need ultrasound. And those people, I mean, I've had patients come in every day to check on situations that were very dicey.
Wow.
You know, certainly twice a week. But they'd be looking at the blood flow in those umbilical cords, the blood flow at the baby's heart, the blood flow to the both babies' brains.
Mm-hmm.
You know, they're looking at the blood flow coming from the placenta as well as going to the placenta, looking at all those dynamics, and then looking to see if the growth of the babies, their size, their difference in sizes, is that getting worse? Is the baby that's getting all that blood, boy, they have to pee a lot. It's like drinking so much water. So they end up in a really big, a big swimming pool of water.
Yeah.
And the baby that's transfusing, it got so little blood, it sort of restricts its blood flow to the kidneys to preserve its circulation.
Yeah.
Like what we do if we are dehydrated.
Yeah.
And so that baby ends up looking like it's shrink wrapped by the membranes because it's not making any pee.
Because the pool has no water.
The pool has no water because the baby's not peeing because kidneys aren't getting enough blood. So there's lots of things to watch closely. That's a high risk situation. And a couple of my colleagues at Evergreen actually are doing that.
Wow.
Yeah.
That is so cool.
They were one of the early adopters in the whole country.
Wow.
So, so that's pretty exciting. Let's see. The other thing is just maybe they're not sharing much in the way of blood vessels, but maybe they're not even identical twins. But where the placenta landed, it doesn't get as good blood flow as where the other baby's placenta landed inside the uterus. So one baby can be growing just fine, getting plenty of nutrition and oxygen and everything, and the other baby's placenta maybe is not getting as good a blood flow, and that baby's small. So you have to watch the babies for their growth. And the baby that's small can be more vulnerable to what's called fetal distress.
Yeah.
Yeah. So all those things can lead to early delivery too.
Wow.
There's also an increased incidence of genetic and structural birth defects in multiple gestations. Okay. The reason isn't really very well understood, but definitely an increased incidence. So I mentioned the cord entanglement. There was overall among multiple gestations an increase in stillbirths and an increase in neonatal mortality. So that twins have to be watched carefully.
Thank you, everyone, for listening. Dr. Rutherford always has lots more to share on this topic, so we decided to break this conversation up into a 2-part episode. We hope you enjoyed today's episode, and please stay tuned for another part 2 coming your way. Thank you so much, and thank you for being our loyal Wellness Wednesday listener. For more information about 3W, please visit our website at 3wmedical.org. That's the number 3, the letter W, medical.org. From there, you can learn more information about the services we provide, book an appointment, or make a donation if you'd like to support our mission. You can also call our office at 206-588-0311. That's 206-588-0311. If you like this episode, please share it with others and consider subscribing on your favorite podcast platform so you never miss an episode. Thank you so much for listening, and until next time, stay healthy and be well.